Welcome everyone to this edition of our webinar series. And tonight we're going to talk about stroke and Fabry disease. And this, not coincidentally, it lines up with our Fabry Disease Awareness Month topic of today, which is also stroke and Fabry, or know your signs of stroke. So that's a good pair for today. Thank you all for being here as always. And our normal routine is that I start the webinar off and I'll introduce Casey McKenna, who is our genetic counselor. She's the Senior Program Manager for Education and Community Support. And she is going to introduce Dr. Nick Abreu, and he's going to give the presentation tonight. So thanks again, and I'll turn it over to you. Oh, and I think hopefully you've all been following our um, almost daily Fabry Disease Awareness Month posts. We're doing them every weekday for this month. So hope you get a chance to read some of the tips we're providing. Casey?
Great. Thanks, Jerry. And thanks, Dr. Bray. We're glad to have you here. Just a quick housekeeping announcements. If you have questions along the way, feel free to pop them in the chat, and I'll be moderating them. So if there's something big going on that we should really pause and make sure we're on the same page, we'll do that. But otherwise, we'll hold the questions until the end. We are recording this presentation, and in the next week or two, we hope to post it to our YouTube channel for everyone to see. Now, without further ado, I'd like to introduce Dr. Nicolas Abreu. Dr. Abreu is an assistant professor of neurology at NYU Langone Health in New York City. He serves as director of the vibrant NYU Lysosomal Storage Disorder Program, providing comprehensive care to children and adults living with lysosomal storage disorders, including Fabry disease. He also serves as the associate director of the Neurogenetics, a division of neurogenetics at NYU. Without further ado, welcome, Dr. Abreu.
Thank you much. Thank you very much, Casey and Jerry, for having me, and for the greater NFDF community for your interest and willingness to participate in today's notable publication webinar. The goal is try to distill meaningful takeaways from the latest research in Fabry disease, really meant to be as a conversation about where we are and where we're going in terms of neurological issues in Fabry disease. I'm a child neurologist by training and have taken over the lysosomal disorder program here at NYU in 2021. And I am not a stroke expert. However, certainly take care of people with strokes from a variety of causes. And so with that context, we'll start. Let me share my screen. So we're reviewing the paper published in 2025 in European Journal of Neurology, Stroke and Fabry Disease, Identification of Risk Factors for Stroke in a Large Single Center Cohort. These are my disclosures, of which some have overlap for Fabry therapies. And we'll run through some brief overview of stroke diagnoses and terms, go through the article, have some initial discussion, then open up to the NFDF for their viewpoint. And then afterwards, we'll do a group Q&A. Really, all questions, really this is meant to help you all. And so any question is appropriate. Just know that I'm not here to provide medical advice. This is really for overall education of neurological manifestations in Fabry. Lysosomal disorders here at NYU. We have a number of individuals under our care team, a number of different providers, including with specialists for Fabry, and some non-Fabry specific gene therapy clinical trials coming forward. And so there's also an NYU Long Island geneticist who also provides lysosomal care. This is the manuscript that we'll discuss today, and we'll go into some more details later. But first, Fabry disease is an X-linked disorder that can affect both men and women with a variety of symptoms due to a deficiency in the alpha-galactosidase A gene, leading to the buildup of certain sphingolipids or glycosphingolipids that are abbreviated GL3 or lyso-GL3. The accumulation of this material in a variety of cells can lead to a range of symptoms, and enzyme as well as genetic testing, really genetic testing to confirm in females especially, but enzyme plus genetic testing in males to confirm the diagnosis. There's a wide range of disease severity that we can see, and we have a number of therapies currently already. This is showing the neuropathy, previously known as acroparesthesia, or the burning pain seen in hands and feet, the skin findings of those purplish spots or angiokeratomas, typically in a bathing suit distribution, problems with the heart and kidney, not shown here. Cerebrovascular or strokes are also increasingly frequent in individuals with Fabry compared to the general population. We know that late onset forms, or what previously was thought as atypical, is actually more common than the classic form. So those with later development of heart problems, kidney problems, or strokes end up being more commonly seen than individuals with more classic phenotypes with childhood onset, often in males assigned at birth who have childhood and then more severe later onset symptoms of heart and kidney. Depending on the underlying gene change, which we'll talk about a little bit later, it can affect the severity of symptoms. And we think that there's a relationship between the severity of symptoms that an individual has based upon the underlying genetic change and the associated enzyme deficiency associated with it. So in individuals who have quote unquote more severe variants or genetic changes, oftentimes that leads to the difficulty to make any enzyme. And so oftentimes less than 1% of any enzyme, that alpha-galactosidase A activity, leads to more severe or classic forms, especially in males, compared to individuals who are able to make more residual enzyme, because the type of genetic change they have, known as missense changes, means that they're able to make some protein, but it's not as functional. And so those that are able to make a little bit more enzyme, functional enzyme, at least as we measure, would be still below the threshold of causing symptoms, but higher, potentially mapping onto the milder phenotype. We'll talk more about genetics later, but what is a stroke? So a stroke is when a part of the brain, spine, or retina is damaged because of sudden loss of blood flow. Well, shown here is a depiction of the arteries in the brain. There are many smaller arteries not shown here, and there are also blood vessels, the veins, not shown here, where any problem in the arteries or veins, if there's a loss of blood flow, that results in a stroke in most cases. We'll talk a bit more about the types of stroke here. So if there's a blockage, or here you can see a large blood clot inside of one of the arteries in the brain, then there's loss of blood flow to that surrounding brain area. We call that ischemic stroke. Or if it happens suddenly in the first 24 to 72 hours, we consider that an acute or sudden ischemic stroke. That's in contrast to when there may be some bursting of the blood vessels where blood leaks out of the blood vessel and into the brain so that there's a brain bleed, what we call a hemorrhagic stroke as neurologists. When we look just at when there's a blockage, we as neurologists classify it further, and you may have heard some of these terms in discussion about either your health issues or health issues in family members. In terms of qualifying the type of stroke, first we decide whether or not there are neurological problems. if someone has no neurological problems, but they have an MRI, for example, a brain imaging test showing evidence of cell injury or death, we label that as a silent stroke. We know that they've had injury at some point, we just don't know when, and that didn't ever cause symptoms. Of course, if there's no neurological problems and no evidence of cell injury or death, that's not a stroke. If there's evidence of neurological problems, even if it's brief, and there's evidence of cell injury or death or changes on MRI that we say, hey, look, this is clear cell injury or death, we label that a sudden or acute ischemic stroke. You may have heard the term transient ischemic attack, or TIA, and that's when there's brief neurological symptoms and we don't see any evidence of cell injury or death when we do the most detailed type of MRI. Now, sometimes there can be things that look like stroke that can cause weakness on one side of the body that resolve and could be after a seizure, for example. That would be what's called a stroke mimic and not actually due to stroke. So we have to be careful when we consider what is or is not a TIA or a transient ischemic attack. But regardless, it's really important to have appropriate neuroimaging, namely a brain MRI, to further categorize if there's these episodes of weakness or sudden neurological change that resolve. Importantly, more than half of people who have a sudden neurological symptom like weakness or slurred speech that get labeled as a TIA just on brief brain scans like a CAT scan end up having evidence of neurological injury when we do more detailed imaging like an MRI. So it's important to make sure that we know the correct imaging done or the type of imaging done to make sure that it was as detailed as possible in anyone with neurological symptoms with Fabry disease. If someone has persistent neurological symptoms lasting more than 24 hours with evidence of cell injury or death, that's still an ischemic stroke. And we still think that these persistent symptoms are likely to be an acute ischemic stroke, even if initial imaging may be negative in a very strong clinical setting. Maybe there's an issue with the type of scan that was done, or maybe we just need more time to see the injury, or it may in fact be a mimic. So overall, have to be careful when we see no evidence of cell injury or death on MRI in particular. This is what we're looking for in MRI, and this is when there's an acute stroke. What's bright on the left-hand side is we're looking at a cut straight through the head at what's called an axial image, and those bright spots are evidence of an acute stroke. And we look for corresponding dark spots on the right-hand side, which you can see in the lower left-hand side and the upper middle portion. And this is what I'm saying by imaging evidence of cell injury or death. Separate from the timing and radiographic classification, we also can say where the type of injury happens can inform what's happening on a pathological basis. So on the right-hand side, you can see these small little blood vessels going into the center of the brain. These small blood vessels are particularly prone to injury or to blockage, especially in things like high blood pressure or hypertension. And if there's a blockage of these, we call it small vessel disease because, as you can see, they are small. This type of injury to these small blood vessels is more common in people with Fabry disease. And we often consider that strokes in the setting of Fabry disease are due to these small vessels being affected. We believe it may be related to buildup of that GL3 or those fatty material that gets built up in people with Fabry disease, building along the lining of the blood vessels. And there's also suggestion maybe there's a component of inflammation going on, but overall, it seems that people with Fabry disease are more likely to have injury to these small blood vessels compared to the larger arteries. of the brain. If a clot forms within a blood vessel in the brain and blocks blood flow, that is thought of as a thrombotic stroke or a thrombosis, the blood clot forming within the blood vessel, versus on the bottom right-hand side, you can see here a blood clot forming elsewhere, like in the heart, traveling from the heart to the brain as an embolus or an embolic stroke. And in people with Fabry-related heart disease, especially atrial fibrillation, an abnormal heart rhythm, they're more likely to develop clots in the heart that then can travel to the brain to cause problems. Regarding stroke symptoms, we currently use the terminology be fast to recognize if someone is having an acute stroke or an acute ischemic stroke. However, it also applies to brain bleeds or other types of injury. And really, it's a sudden onset where someone was previously completely normal to all of a sudden a new change, causing problems with balance, vision loss especially, drooping of one side of the face, weakness on one part of the body, slurring of speech, and then anytime that these are sudden onset and persistent, it's important to call 911 to seek urgent medical attention. Not everything, there are a lot of other things besides stroke that can cause these symptoms, but because the issues with stroke can be so significant and profound for an individual, wanting to make sure we get urgent medical attention is important. What we know about Fabry disease and stroke before this paper is that stroke is more common in people with Fabry than the general population. And as someone gets older, there's an increased likelihood of stroke. In larger cohort studies, the likelihood of a man developing stroke with Fabry is somewhere between 7 to 15%, while women is somewhere between 4 to 11%. It can affect people of a wide range of ages, although most often it's in early middle adulthood. And oftentimes it's where there's a blockage of blood flow or ischemic stroke rather than a brain bleed, although all types of stroke happen. We talked a bit previously about why strokes happen in Fabry disease, so I won't review it. This is the article of which I have no affiliation with. It was primarily driven out of a number of researchers who, especially Dr. Hughes, a prominent Fabry specialist, studied a group of people out of one hospital in London, specifically the Royal Free Hospital NHS Foundation Trust, and also affiliated with the University College London. When I review journal articles, I like to take a PICO approach, reviewing the population, the intervention, comparison, and outcome. In this study, they analyzed adults with Fabry disease over 18 years of age with at least one follow-up at their institution by March 2019. So that's when they stopped collecting data. They analyzed this based upon their existing medical record, just reviewed retrospectively or in the past, and they didn't look at any intervention in the study. It wasn't giving a new medication or experimental therapy. They didn't compare people with Fabry disease to any other group, and they looked within subgroups of people with Fabry disease, looking at potential risk factors for development of stroke in this group, and they conducted survival analyses. It's very important to know for survival analyses, they aren't saying survival in terms of life or death. They're saying survival in terms of whether or not someone developed a stroke. So in this case, surviving means free from stroke, and failure or not quote unquote surviving is development of a stroke, even though people could live very long after development of a stroke. They also did a nomogram analysis to help individuals more find a way to better assess their risk for having a stroke based upon a variety of factors from their analyses. This study did not look at those TIAs, those transient ischemic attacks or sudden neurological symptoms that resolve, for which there aren't MRI evidence of injury. And they were able to look backwards at 368 people living with Fabry disease, of which the majority were women, over a median follow-up period of 10 years. The age at first stroke was somewhere between 50 to 51 years of age in most individuals. And looking between this 25 to 75% range of what the average age is, you can see they're generally between 40 to 60 for the majority, 50% of both men and women. They looked at some baseline features, and so that neuropathy or the pain-like symptoms in hands and feet, changes to the white matter of certain parts of the brain that are common in Fabry, as well as stroke risk seem to be similar between men and women assigned at birth, despite men assigned at birth having more significant cardiac and heart and kidney problems. In their group, they found that about 19% or 69 people had strokes, and the youngest in their group was 26 years of age. They found that lacunar or those small vessel strokes were more common than large vessel strokes. And that seems to be consistent with what we've seen in other studies. A large minority of individuals had what we discussed as silent strokes, where they never had symptoms, but they got an MRI and they showed a prior potential stroke. In terms of risk factors, from what they did a number of different analyses in terms of a variety of clinical factors about what may be associated with stroke. They analyzed each factor and whether or not it was associated with or without having a stroke. And then they compiled those that were statistically significant into more detailed analyses, or going from a univariate analysis to a multivariate analysis, which is statistically more rigorous or a stronger type of analysis to really try to tease apart, okay, what is actually driving these strokes in this population? Highlighted in bold are the ones that came out to be clinically or statistically significant, in those more statistically rigorous models or the multivariate analyses, while those non-bolded were identified in the univariate analysis or just comparing one clinical factor to stroke risk. And so older age, as well as specific gene changes, were associated with people who are older had an increased risk for stroke. One particular genetic change that was associated more with later onset heart disease seemed to be protective for stroke risk, but we'll talk more about that. Measuring lyso-GL3 and GL3 seemed to be associated with increased stroke risk. Having those dots on the bathing suit distribution, the angiokeratoma, seemed to be associated with increased stroke risk, and same thing with the burning pain and high blood pressure. Kidney disease was one that was associated with increased stroke risk and also survived the more statistically rigorous approach. Same thing with arrhythmia and enlarged heart and white matter disease did not survive the more statistically rigorous approach or the multivariate analysis. Autoimmune disease, although uncommon, seemed to increase risk of someone's stroke, and having a hole in the heart, which is an anatomically normal variant or a patent foramen ovale, also seemed to be associated with an increased risk of stroke, although they had a very, very small number of people with a PFO. This is what I meant by the more statistically rigorous approach, looking at what variables really drove the increased stroke risk. And so this is including many of these clinical factors together in a single analysis to see which ended up being statistically significant when the others were also included in the analysis, because sometimes two things can be clinically significant or statistically significant, but one is really driving the other. And so this helps to tease apart which of multiple factors may be driving stroke risk. They used something called a hazard ratio to say whether or not something was how it affected stroke risk. And so a higher hazard ratio, really above 1, is associated with an increased risk of stroke, whereas less than 1 seem to be protective against stroke or reduced risk of stroke. You can see here that one particular genetic change, this missense change, which is associated with later onset heart related symptoms or disease, seem to be a protective, seem to have a protective effect on stroke risk. However, something like autoimmunity had an increased stroke risk, and having a normal or high healthy kidney function. So eGFR is a measure of kidney function. The lower the GFR, the more significant someone's kidney disease is. So high kidney function seems to be protective of stroke risk. And those were all what are known as statistically significant, or a p-value less than 0.05 in this multivariate analysis. They discuss at length the fact that there seemed to be a relationship between non-stroke related brain MRI changes, known as white matter lesions, and that seemed to correlate or closely mirror someone's kidney function, which is also seen in general in people without Fabry, adult populations. And so that, even though white matter disease didn't show up as a predictor, it likely is because it was mirroring what was going on with kidney function. One thing that all of us are concerned about is how is stroke risk mitigated or affected by the kind of therapy you're on. And none of the treatment, they did look at what treatments people were on, including egalsidase beta, egalsidase alpha, as well as megalostat, and here, at least in the more sensitive or more rigorous analysis, adjusting for sex and genotype, megalostat was on the cusp of statistically significant, being protective for stroke risk compared to egalsidase alpha. And in terms of ERT of any kind versus megalostat, there may have been a increased risk of stroke, although a very wide confidence interval, potentially suggesting a protective effect of megalostat compared to any ERT, but megalostat versus egalsidase beta, or Galafold versus Fabrazyme, there is no statistically significant difference between the two in this study, at least in terms of effect on stroke. Now, one of their takeaways was this nomogram, in terms of using multiple different clinical factors to try to predict someone's risk of having a stroke. And so the idea was to develop a system by which someone could say whether or not they had certain clinical variables and use their age to then determine what the probability of being stroke-free at that given age would be. So if we take a case of a 60-year-old with Fabry disease and no evidence of heart or kidney disease, without angiokeratomas or autoimmune disease, and not without that late onset, primarily heart-specific genetic change, what's the likelihood of them being stroke-free at at that age. You can see here an MRI form of this patient, this theoretical patient, although it's a different individual. And you can see these little white spots. This is in top part of the brain, then through more of the middle of the brain, sliced through this way, and then more of the lower part of the brain. And we're looking for these white spots, which are common in people with Fabry disease and around the fluid-filled space of the brain or the ventricles. And these are evidence of white matter disease. So if we take her case over to the nomogram, or what the authors provided, we first see that the first is for white matter lesions. And yes, we saw those white matter lesions. We said there was no kidney involvement. We assumed her doctors were checking her creatinine and glomerular filtration rate, and it was higher than 90. We knew that there was no autoimmune disease. There were none of those skin findings or angiokeratomas, and she did not have the typical late onset cardiac genetic change, and she was a female. We can look down the scores at the bottom and see for white matter lesions that maps onto a score of 6. All these others are 0 except for the genetic change that gives her an additional score of 10 for a total score of 16. We then use that score of 16 to go to the next section of the nomogram and say, okay, she was 60 years. We know that with increased age, there's an increased risk of stroke. So we look at the green line about where this individual would fall in terms of their stroke-free, their chance of being stroke-free, and go to a total score of 16 and draw a line right here. And in that point, we can estimate, based upon the data that this was pulled from, that the stroke-free survival would be somewhere between 0.35 to 0.4. So what are my takeaways from this? One, we already knew that stroke or TIA is increasing, there's a higher risk in people with Fabry compared to the general population. This study had a slightly higher risk of stroke compared to other studies. However, this study was about half the size of a very large study done in 2009 with over 138 people with stroke, studying more than 2,000 people with Fabry disease. So I think this is a bit of an overestimate based upon it being a single center study. They do have some nice data looking at the types of stroke that occurred, overall providing additional support for those small vessels being more likely to be affected in people with Fabry disease. We already knew a number of risk factors in people with Fabry disease for developing stroke, and this gave further support for age, increasing age, renal disease, maybe certain genetic changes, and even potentially autoimmunity as risk factors for stroke. They had a very small number of individuals with autoimmune disease, and that ranged from things like rheumatoid arthritis, thyroid disease, and Sjogren's disease. The thought is that some of these conditions may cause inflammation, not only in the body, but also in the blood vessels of the brain that could increase the risk of someone developing stroke, which is known in people outside of Fabry disease, with some of these conditions being associated with stroke, just like rheumatoid arthritis or lupus. The genotype, I think, is an issue related to the patient population. They had a large number of these individuals with one specific form of Fabry disease, this late onset heart specific form with the N215S. And really, we need more genetic diversity included in these studies, or people with different types of genetic changes, to really say, is it the N215S genetic change being protective, or is it just that any one of these later onset genetic changes may be less severe, and individuals who have less severe disease overall may be more likely to have less neurological symptoms or less stroke. Some studies have shown that males are more likely to have strokes compared to women. This study did not show that. And I think from anything, this is just a reminder that we need to make sure that females undergo comprehensive Fabry monitoring, including for neurological disease. The question about whether or not a PFO is contributing to stroke risk is hotly debated, both especially outside of Fabry disease, and whether or not we should mechanically close these. The literature goes back and forth about the utility of this, and the sample size of individuals with these small holes in their heart is insufficient to make meaningful conclusions, in my opinion. And this question about these other changes on MRI that aren't related to stroke or white matter disease, I think it's controversial about what their meaningfulness is for stroke risk. It may be a sign of subtle small vessel disease, but hard to say.
I missed, what was PFO?
Patent foramen ovale. That is a small hole in the heart that's oftentimes closed in young children, but some people just have it open for a variety of reasons, that it just doesn't close normally as in children, and can potentially transmit a blood clot from one side of the heart to the other, that then can travel from a clot from the legs, can travel to the brain through that hole.
Thank you. Could you go back one slide? I think it was one slide. Yes. So can you, I didn't quite, when it says stroke risk survival, 0.35 to 0.40, what does that mean translated?
Yeah, that means the probability of this individual of being stroke-free at 60 years of age is 35 to 40%.
Okay, thank you.
This is drawn from the main study from 2009 that wasn't in this paper. This is a lot to say that it's just stroke may occur before the diagnosis of Fabry disease and without other clinical events. And so oftentimes neurologists aren't thinking of, so to see for main thing is in the bottom left-hand side for people who had only strokes, about 20% of males only had strokes, but 42% of males in this group had strokes before kidney or heart problems, and that about 30% had, this is 50% had strokes before kidney or heart involvement, about 30%, excuse me, but 25 individuals total had kidney or heart disease before they developed stroke. In contrast, females had about 50% of strokes as their only major clinical manifestation of Fabry disease, in contrast to about 25% having strokes before kidney or heart disease, and only about a little more than 20% having kidney or heart disease before strokes. And the message here is that strokes may occur before the Fabry disease diagnosis and without other clinical events. So when taking a family history or when talking to other family members with Fabry disease, it's important to ask about stroke. And that for neurologists, if they do see strokes in an individual, to start thinking about are all these other symptoms, whether it's pain in the hands and feet, heart disease, kidney disease, the angiokeratomas, and that really we need to be thinking about Fabry and stroke more often. Finally, time is brain and Fabry disease. This is unrelated to what was talked about in the manuscript, but really any time that someone has persistent and sudden onset neurological symptoms, that we need urgent medical attention in Fabry disease if we think that a stroke is going on. There are treatments that can be given via the vein to bust a clot within 4.5 hours, or even to mechanically remove a clot through thrombectomy. and so knowing when their last known well time is really critical for neurologists to make a decision about what to do. There's also a lot of comprehensive medical options that can be provided besides these acute treatments. And then we're still in the works about what to do to try to prevent strokes in the first place and what to do to prevent strokes from happening again in people with Fabry disease. And there are a number of different medical therapies that are now being used for what's known as secondary prevention, or what to do after a stroke has already happened to prevent them from happening again. I guess ignoring this big slide, I do want to say, what do we know about Fabry therapies and their effect on stroke? This study showed maybe there is some effect of migalastat, but not clearly, it wasn't looking at superiority or inferiority. From what we know from enzyme replacement therapy, there may be some improvement in terms of stroke rate, going from 11% in natural history studies down to 5 to 10% in those who are on ERT. And another study showed that starting enzyme replacement therapy like agalsidase alpha or beta before a major cardiac or renal event leads to fewer strokes than after one of these events occurs. Pretty much the earlier we treat, the better. So Casey and Jerry, wanted to get your thoughts and then open it up to the audience.
Yeah, I think very interesting information. I think stroke is one of those things that's just more scary than other things. And to me, and one reason is that there's very little that you can do in my mind. Tell me if I'm mistaken. But when I go to my neurologist and I say, I am managing my blood pressure, I'm managing my cholesterol, I'm getting physical activity, I'm getting enough sleep, I am, what am I missing? I'm doing all the things that reduce my stroke risk. What else can I do? Nothing's direct. I mean, what else can you do? And there isn't much else you can do besides take care of all of those lifestyle things that reduce your risk of stroke. But I think it's scary with strokes because just personally, I have a female cousin who, I don't want to scare anyone, but it's just the facts. It happens. She, at 49 years old, she had her first symptom of Fabry, which was a stroke that she died from, which is horribly scary, tragedy. But we all just need to make sure that we're taking all of the precautions we can to reduce stroke risk. But great information. I think it's very interesting.
Yeah. Thank you, Dr. Abreu. Yes. Well, what kind of practical guidance can you give to someone who's unsure if it's time to go to the hospital or not?
Yes. In general, anytime that there's a persistent neurological problem, so that's weakness of that BFAST,
Yeah.
that really is lasting more than a few minutes, I would seek urgent medical attention, because as we discussed, even those things that are quote unquote TIAs, oftentimes we can see things in up to half of individuals on the more detailed neuroimaging or MRI, even if it is only lasting 15 minutes or an hour. And because we can sometimes have treatments for those cases, seeking urgent care and making sure that we know what's going on can be very helpful. It is hard because one of them is like balance problems, and like sometimes you get like you stand up too quickly from a seated position, and then you get dizzy, and like dizziness and balance problems can also be common in people with Fabry disease due to problems with the eighth nerve being affected, causing hearing loss, balance problems, vertigo. So it really has to be almost like it really should be quick in onset, sudden, and really a significant change from someone's normal life, where like, okay, I get dizzy or I have balance problems from time to time, and I don't normally slur my speech or get weak on one part of the body. That's odd. Even if it does get better over the course of 15, 30 minutes, still worth having it checked out. The other issue is that even if it does start to improve, sometimes we see what are known as stuttering strokes, where blood flow is only partially blocked. And so sometimes those symptoms can come back. And that's where, again, being proactive about treatment, we can try to keep blood flow going for as long as possible, either through blood pressure control or through some of these acute treatment options.
Yeah, I think in my reading, I heard about people calling a TIA a warning stroke.
Yeah, I would be, we previously TIAs used to be purely defined based upon um, duration of symptoms,
Okay.
and now we're including both duration of symptoms and the absence of neuroimaging
Okay.
changes. And so I'd say um, it's really important that a stroke could very well be happening even if someone has resolved symptoms.
Mhm.
It's just uh, they need detailed imaging to make that determination if it's a warning, like nothing actually happened or no brain tissue was affected versus
Mhm.
brain tissue was affected on MRI.
Okay, gotcha. Thank you. Okay, so questions from the chat. The first one is a little bit more general about adults. Do you see people using blood thinners as a preventative measure for stroke and Fabry disease?
Yes. So in my practice and in what my understanding of the literature is that whether it's low dose aspirin, antiplatelet clopidogrel or Plavix, or stronger therapeutic anticoagulation, those all have places in secondary prevention. So after a stroke has already happened, but because they all may be associated with increased risk for bleeding, not only bleeding in the brain, but in other parts of the body, that for primary prevention, we don't yet have enough data to suggest their use for preventing strokes from happening in the first place. Sometimes they're used for people who have known heart disease, and especially therapeutic anticoagulation may be needed to prevent strokes in people who have one particular abnormal heart rhythm called atrial fibrillation in the right context. So absolutely, they could be appropriate in the right context, but I'd be cautious for their use in people with Fabry disease without a prior known stroke. That could be, though, in the setting of a silent stroke. So making sure that we know what the baseline MRI is. Um, and so, yes, ultimately, it's still an open question about primary prevention. Fabrazyme does not cross the blood-brain barrier, but we're talking about the blood vessels in the brain, which Fabrazyme gets to. So we think that at least the small vessel problem and the reason for strokes is that the GL3 or that fatty material gets lodged in the lining of the blood vessels, which Fabrazyme can get to, or any other enzyme replacement therapy. I don't know the data on newer enzyme replacement therapies on their effectiveness in a stroke, like peganogalsidase, but um, you're correct that migalastat does seem to cross the blood-brain barrier.
So I have a question. Can untreated sleep apnea put you at higher risk of a stroke? And what
Yes,
happens there?
yeah. Um, in general, untreated sleep apnea is associated with increased cerebrovascular and cardiovascular events, namely increased risk of heart disease and stroke. And so we understand that people with Fabry disease are at increased risk for obstructive sleep apnea. And so appropriate sleep evaluation, especially those who may have symptoms of morning headaches, poor sleep, snoring at night, or waking up gasping, making sure that they undergo an appropriate sleep evaluation. And whether or not everyone should be screened is a separate question, but yeah, you're right.
And I learned I was diagnosed with sleep apnea, and I wore the CPAP machine for a long time. And then I had a second, maybe even third sleep study and discovered that my sleep apnea is positional. So as long as I sleep on my side, I don't have sleep apnea. So just for some of you others to think about if you've been diagnosed, make sure that they address that, whether you always have sleep apnea or just if you sleep on your front or back.
And can I ask you to please highlight what is a retinal or ocular stroke? And is that something that people with Fabry disease are at risk for?
So when we use stroke, the nervous system is more than just the brain. It
Mhm.
also includes the retina as well as the spinal cord. While those are less common, the blood vessels to the eye are small. And so while I think retinal strokes are quite uncommon overall, including in Fabry disease, more often what we see in the retinal changes in Fabry disease are related to some thickened or tortuous arteries, just especially curved, not necessarily following the straight patterns that we would see. Oftentimes that happens in people with higher, can be related to blood pressure or kidney disease, but I, I don't have data specifically on, or I don't know about these retinal stroke frequencies
Mhm.
in Fabry because it's generally not well studied. Oftentimes, when we think about it, it's sudden vision loss, typically like a curtain going down over someone's eyes, and it would really be sudden vision loss, not like floaters or zigzag lines or kind of any number of problems. It really should be sudden loss of vision.
Okay. So sudden loss of vision is an emergency.
Correct.
Excellent. Thank you.
Like most things, I have a long resume and I have some experience with this also. So once I experienced what you're talking about, where I had a curtain go down over my left eye, I had flashes of light, curtain floaters, and eventually went blind in my left eye temporarily. And I got a diagnosis of something called amaurosis fugax, which I think is just a medical term for an occlusion in the vessel. Who knows whether it was caused by Fabry, but there's probably some likelihood that it was in my case. So I know it can happen. I don't know how prevalent it is, but that was really scary to go blind suddenly and not know why. But it all resolved and life is good again. Oh, and I would say it if you I had all the symptoms of a retinal detachment, which is all the things that you described.
Mhm.
All right. And the last thing is I missed one on my stroke risk list, and that was eating healthily. So eat well. All right. Thank you so much, Dr. Abreu. Thank you, Casey. Thank you all for being here, and we hope to see you on our next webinar. Good night, everyone.